All right. Well, I've got the top of the hour. I want to thank everyone for joining us today, and we want to be respectful of everyone's time. So we're going to go ahead and get started. My name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. We cover the states of Indiana, Illinois, Michigan, and Ohio. And today we've got with us Tony Song from Diabetes Care Partners. Just a couple of housekeeping items before we turn everything over to him. We always have to tell you about our National Consortium of Telehealth Resource Centers. And Aria, if you would advance the slides here. So we can't have a National Consortium of Telehealth Resource Center webinar without having the map of the 14 of us. So there are 12 regional telehealth resource centers and 2 national telehealth resource centers. We are all federally funded through HRSA, through the Federal Office of Rural Health Policy and the Office for Advancement of Telehealth. The program itself has been around since 2006, and we are happy to be talking with you today and sharing information about diabetes. Next slide, Tony. Or I'm sorry, Aria. Just some tips and tricks. Everyone that has joined us today has been put into listen-only mode. At the bottom of your Zoom window, you should see a Q&A button. We ask that you put your questions there. I will not interrupt Tony unless there's a really specific question that everybody needs to know about the particular slides. We'll save questions till the end. If you have any technical issues, then use the chat function to chat with Aria. The slides will be made available and the recording will be made available after the event, so in a couple of days. And we do have transcriptioning going on today. We get to be the guinea pigs for the new transcription service for the National Consortium of Telehealth Resource Centers webinar series. We will have a Q&A at the end. And there's the links there where things will be posted and how to get to all of the 14 telehealth resource centers. So I think without further ado, I'm going to hand things off to Tony, and I'm so looking forward to this presentation. I've talked with Tony several times and heard his presentation a couple of times, and every time he gives this program, I learn more. And as being the parent of a type 1 diabetic teenager, it means so much to me to have these resources. So thank you, Tony, for joining us today.
Of course. Thank you, Becky. Appreciate the introduction and really the opportunity to present today on the importance of telehealth in diabetes education and support. I also want to thank everybody for joining us today. As many times as we do these webinars, it's always strange to talk into the void, right? I know you're there. I see that there's 65 people online, but I don't see you. But if you would be so kind to chat in the chat box where you're connecting from, what city and state. I'd love to know where you guys are. So Pomona, Lisa, I know Lisa. Ashley, Telluride, awesome. Milwaukee with, they're coming in too fast. All right, great. Kimberly from Austin. Wow, you guys are from everywhere. San Francisco, in the same state that we're at. And of course, Brenda. Hey, Brenda. I'm actually located here in West Covina, California, and that's about 10 miles east of Pasadena, if you're not familiar with that. Most people know West Covina from the sitcom My Crazy Ex-Girlfriend. If you ever watched that, they actually have it setting here in West Covina. But yeah, I appreciate all those chats. That's great. Everybody from everywhere, from Rome, Georgia, Pittsburgh, Carrie from Salt Lake City, Wendy from Louisiana. Oh, they're still coming in. All right. Excellent. Excellent. Great. So today we're going to talk about one of my favorite topics, mistakes, myths, and misconceptions your telehealth diabetes programs need to avoid to be successful. a little bit about myself. I am the CEO of Diabetes Care Partners, but really, I think the most important title I have is PWD. And if you don't know what that is, it's person living with diabetes. I've lived with diabetes for more than 10 years. And I feel that that personal connection to diabetes is what makes our company and the direction that it goes to the best way that it can be, because it goes through a lens of a person that lives with diabetes. And you'll see throughout the program here that we really concentrate on experience. What is that person that has diabetes going through in their lives to want to come to a diabetes program, and especially a telehealth, to get the help that they need, really. So the two things that we go that are the foundations of our program is, number one, the lens that we look through, and of course the second is our mission and purpose on why we're here. And you can see it from that picture. That's me at pre-diabetes, 230 pounds. I've definitely gone a long way. I'm 165 pounds currently, but it's definitely doable. This is our mission. Our mission is what we focus on every day, is to provide increased access to outcomes-driven, meaningful, innovative health education solution and support for all, everyone. If we could figure it out, we'd want to help every single person that has diabetes and pre-diabetes get empowered to live a healthier life. That's our goal, and we're slowly getting there. A little bit about us, just real quick. We were founded in 2003 and have been an ADA recognized program since 2006. We really started telehealth in about 2013. Currently, we manage over 36 remote sites, over 900 miles spanning the states of Oregon, Nevada, and the Mexico border. So needless to say, we've seen a thing or two about diabetes and telehealth. But I want to start this this webinar by asking you a real simple question. It really is kind of an experiment. The experiment is, have a look at this. I want to know in the chat, how many blocks do you see? Let me see it in the chat. How many blocks do you see in this? And I'll actually make it bigger so that you guys can see it. Too many to count, Carrie says. I mean the bigger blocks. 20. I hear 20. Heidi says 20. Barry says 20. Aaron, Tony says 20. Okay, great. And I would say you're absolutely right. There's 20. Now it gets a little bit harder. Let me ask you, how many circles do you see here? How many circles do you see in that same picture? All right, I see some zeros, I see some 16s, I see some hmms. Okay. Well, I'll tell you that about 95% of the people can't see the circles. So you're not alone if you can't see it. But what if I told you there were actually, and the people that wrote down 16 are absolutely right, and they're in plain sight. It's truly crazy. And you know, I was part of the 95%, by the way, that didn't see it the first time. So how can this be? You may ask yourself, well, where are they? Well, let me show you. There they are. Now, if that was interesting, can you type in aha in the chat? Yeah. Carrie, Tony says aha. Melissa, aha. So this is an example of, you know, that you see what you don't know is the hardest knowledge to come by. So what you don't know, you don't know. But once you know, your perspective changes forever. Because if you ever see this experiment again, you'll know exactly that they're 16. You'll know where to look, right? But at the very beginning, it's really hard to see. It's what you don't know, you don't know. So I'm hoping I can give you a different perspective today about telehealth and diabetes program, just like this experiment. So when we first started the COVID pandemic, and we had to switch over to telehealth, and most of us that switched over to telehealth that weren't doing telehealth before, you probably were feeling, well, you know what? If you build it, they will come, right? I think most of us were hoping that that was true. And why not? I mean, look at the value of telehealth. You increase access, you save time, you save money. You know, the patient doesn't have to take any days off. They don't need to take childcare, and they can do it from the convenience of their home. I mean, what more can you ask for, right? And I like to call this the cautionary tale of the shiny object syndrome. Yep. Because as great as the telehealth delivery model is, it is not of in itself the solution, right? Many programs thought that taking their in-person programs, just broadcasting through this new medium, would translate the same, but in most cases it didn't. In fact, what we see is that any problems with inefficiencies, engagement, and outcomes with your current program would be magnified when using telehealth to scale. So what we saw was low attendance and engagement. We saw a decrease in referrals for telehealth diabetes self-management trainings. Because of that, we saw less people receiving diabetes education. And unfortunately, because of that, programs were downsized or closed. And unfortunately, some diabetes educators lost their jobs. You know, this didn't have to be. So when we asked a lot of the programs out there that were going through these struggles, and not saying that everyone had these struggles, by the way, there was a lot of programs that actually succeeded in telehealth during the COVID pandemic. But I would say the majority probably went through this cycle. And when we asked them what were the things that they thought contributed to this, they told us a couple, at least 4 things that I want to talk about today. And I want to call this section myths and truths. So the first thing that I heard was, my patients don't want to use telehealth. So in the chat, if you believe this, can you go ahead and put yes or no in the chat? I'd like to know what you guys think. Oh, I see a lot of no's, or I see 2 no's, 3 no's, 4. I see a yes. Some do. 50-50. Okay, no, no. All right, 50-50, no. Depends on the patient. Absolutely, Wendy. Depends on the patient. Absolutely. So I want to show you this chart. This is a chart of the health claims, telehealth claims data during our public health emergency. And this is from the Healthcare Coalition Telehealth Work Group. You can see that spike. It's almost 13 million telehealth claims per month at its peak. You know, providers were offering telehealth, but maybe not well, but they were trying and people were responding to it. You know, let's go ahead and dive deeper into this data, because I think it's very interesting on who is offering these telehealth services. You see that blue line? That is the behavioral and mental health providers. They accounted for almost half of the telehealth services. And then you can see the rest are pretty substantial as well compared to where they were. And that makes sense for behavioral and mental health providers, because people were going through very stressful times. But one thing to keep in mind is that these providers were also experienced in telehealth before the emergency, as most telehealths were already being done in this space. So although the others weren't doing it and they actually started to do a lot more, you can see that because of the experience that the behavioral and mental health workers had, they were way above the curve. But the fact remains that patients wanted and accepted telehealth when provided without much hesitation, right? So I want to point out, that excuse me. I want to point out that the diabetes care and education specialists perform very similar services to the behavioral and mental health providers. Most CDCDES providers will tell you that it feels like they're there for emotional support more than anything else, to help with diabetes anxiety, denial, feelings of overwhelmingness, loneliness, burnout, frustration. That's why telehealth is so perfect for diabetes education and support. But I fear that most programs are missing the boat. So let me tell you what has happened with our program through the public health emergency as an example of this opportunity. So prior to COVID, we were seeing 32 new group cohorts of people living with diabetes each month at doctors' offices, community centers, and our own facilities. So I wanted to show you this picture. These are pictures of some of the places that we've done our program at. Most of them are at physicians' offices. Some of them are at community centers. During the COVID, obviously, we weren't able to do group sessions. And so we had to pivot to more one-on-ones and in-home group sessions, meaning that they were Zooming in from home and not getting together at a particular facility. But when we pivoted, we actually had an increase of 313% of our referral sources. And during that same time, we did over 6,000 telehealth sessions. And currently, we have roughly about a 4-week waiting list for our members to participate. Essentially, we saw the same growth you saw from the previous slide for mental health providers in our own practice. I believe it's because we were ready. We're playing the long game and it paid off, just like for behavioral and mental health providers. So I'm not showing this data to brag. I'm not showing you this to tell you what we've done. I'm showing you this because I want to make sure that you know that this is the potential for you. We're not special. We just saw and acted on and played the long game for members to provide this to our members by investing in telehealth early. So the statement that my patients don't want to use telehealth was not true for those programs and providers who were already ready to provide telehealth. So some of the lessons learned that we had is, first of all, telehealth isn't for everybody, right? Again, it's not the magic bullet, but it is the best tool we have today to increase access to our services that is remarkably scalable. First of all, we do have to find the value for the patient. I do a whole talk on value because it's so important. Just like the experiment we did at the beginning of this webinar, each patient's value can be hidden. It's sometimes what they don't know that is valuable. I feel we don't find and convey the value as well as we can in diabetes education. But once you figure it out with that patient, it gets so much easier for them to enroll into any program, let alone telehealth programs. The next lesson we learned was to become really frictionless. Another reason for hesitation to telehealth was that patients felt it was too difficult to learn or to try to understand. That's their preconceived notion, but it's ours as well. You know, we had many people say that they didn't want telehealth at the beginning, but once we showed them how easy it was, and we made it easy, by the way, and they actually took part in a telehealth um, session. They really took pride in their newly found knowledge and thanked us for helping them come into the 21st century. In fact, many said that by participating in a program, they were also able to use the knowledge to attend their church via Zoom. Now, if that's not empowerment, I don't know what is, right? So you have to identify the main points of friction for the patients to participate in your program and help support them through it. That is the key. Here's another one. My patients don't have the equipment and internet access for telehealth. Please type yes or no in the chat if you believe this or if this is true. Amen. Ashley says amen. Yes, Rebecca. True. Michelle says true for many. Most don't, says Heidi. Medicaid patients, true. Yeah, older patients don't have equipment. Absolutely. Most patients don't have smartphone to access. And that is absolutely true. Absolutely. The digital divide is real. This is from information from the Pew Research. 21 million Americans don't have internet. 3 in 10 people, 27% in rural places don't have internet. And this would really shock me. 60% of healthcare facilities outside metropolitan areas don't have broadband connection. I mean, how are we doing our jobs without that? So, the digital divide is absolutely 100% real. So for the ones that said that, that's what you're seeing. We see that too. We live in a metropolitan area in Los Angeles, but we still have deserts of patients or members that just don't have these things. But what we do have, let's look at that. And this may not apply to everyone on this call, but this is what we do know, that 97% of people have cell phones. And so we're possibly able to do a phone consult with them. But 85% of the people, according to the Pew Institute, have smartphones. And so that's a good thing. From 95 to 96% of age 18 to 49 have smartphones. So we're talking about the younger crowd. For the older members, 61% age 65 have smartphones, and smartphone dependency is most common in younger adults and lower income Americans. So you got to look at these numbers and know where your opportunity is. And so the lessons learned here really are, build your strategy for mobile. That's what we did. We implemented a lot of text messaging strategies to make sure that we were able to connect with the majority of people that probably didn't have in-home Wi-Fi, but they definitely had smartphones. And that was a big portion of the people that we took care of. The other thing is have discussions with your payer. Your payer has the exact same goals as you. They want their members to be healthy. And if you're able to provide that, they're on board, but you have to have discussions with them and be creative. So I want to show you what we've done with some of our payers. So let me back out here a little bit so I can see you. So what we've done with some of our payers, one that's called Bright Health or Brand New Day, is that we've actually started a pilot using something like this. There you go. So it's an iPad. And we implemented this iPad with a specific integration of a patient-focused interface on it. It was very, very simple to use. And we're piloting that. And it was a suggestion that we came up with them because we realized that there were so many members that we weren't able to connect with because they didn't have, number one, Wi-Fi, number two, they didn't have a device. So we asked them, is there something that we can do together to take care of this? And so they said, yes, let's try this, right? And so that's the first step, is to talk to your partners to try to figure out, is there a way to do something? Instead of just sitting back and saying, well, you know what, we're just gonna wait and see, or, if they don't have it, well, that's just too bad. We got to move forward. And the health plan was actually going to pay for the connected portion of this iPad. So they would pay the AT&T bill, right? And they're actually even thinking about even paying for Wi-Fi in a member's home. And I know that there is a new program with the FCC that I believe Becky is going to probably tell you about maybe later, that provides a subsidy for broadband and devices that just was released maybe about maybe 5 days ago, I understand. So I think that's definitely something that's coming in the queue, and something that we definitely need. I'm so happy that this is happening. The other thing on lessons learned for this is partner with local community resources. If your members your patients don't have devices and they don't have internet in their homes, what about the local pharmacy or local senior center? And I know that we can't get in groups at this point, but once things open up, that might definitely be an option to partner with people to do that. That's what we started doing. Like I said, the majority of our telehealth were at doctor's offices and community centers. How about this one? Doctors don't want to refer to telehealth programs. How do you guys feel about that? I heard a lot of that when I was talking to other, programs. I disagree. Depends on the doc. Absolutely. So, as most of you probably already know, referrals before the PHE were low anyways. I mean, it was documented that less than 5% of Medicare beneficiaries received diabetes self-management training, and less than 7% of private insurance members received diabetes management training as well. I mean, these are numbers that should be, I would think, at least in the 20s, the 30s, if not the 70s and 80s, right? So the fact of the matter is that, the doctors and all healthcare professionals are extremely busy and have probably been overwhelmed during the past year, right? Diabetes education is not at the forefront of their mind, but it should be. And I'm going to show you some data that shows that we need to be there for our members. So the thing that we've done over the last 20 years is really create that strong relationship with the physician, right? Because if they don't refer a member to you, you don't get that opportunity to take care of them. So the more you can build that relationship, and I don't know if a lot of programs have that in the forefront of their mind, regular in-services are key. We should be doing that all the time. And you would be amazed that physicians don't have time to train their staff, their MAs. I mean, the MAs know certain things, but they don't really know about diabetes, and you guys are the expert at it. So why not have regular in-services to train them? Because in a sense, by doing that, you become a part of their team, and you're starting to build that better relationship. Consistent follow-up. One of the things I heard a lot from physicians was, when I send somebody to that education center, I never hear back from them. I don't know exactly what's happening with that patient. But then, a lot of times, let's say the patient comes back and there's no difference in their A1C or their blood sugar. they automatically blame the center, saying, well, you know what, they didn't really do a good job probably, and and so that leads to that degradation of that relationship. So we have to consistently communicate with those doctors to make sure that they know that we're bringing value, right? Because value is the key. If we don't show value for them, it means nothing to them to send anybody. One of the truly best strategies that we've used is in-office telehealth services. Now, I showed you those pictures earlier, and those are at doctors' offices. And we actually do them at the doctor's office, either during their lunch break when nobody's in the waiting room, or if they have a big enough conference room, we'll go ahead and do it there as well. Doctors love that because, number one, the service feels, at least to the patient, that it's coming from the doctor, right? And so the doctor gets huge credits. So that's awesome. I love that. The second thing is they know exactly what's happening with that member because they're there at the office with you via telehealth, but with you. So they don't feel so disconnected to the patient, sending them to a center. And because of that, we feel that a lot of our doctors really embraced telehealth because they said, wow, I see that and I see the results from it. And so I'm going to send all my patients to you. A lot of them do. So I want to show you this quick video. This is one of our doctors that we work with. His name is Dr. Gergis. And we've been doing telehealth programs in his office for a good, I think probably a good solid, well, before the pandemic, a good solid 6 months. And he started seeing the results. So I want to share with you a little video that I made. And he was gracious to do this for us. So let me go and share that for you real quick.
I think that this program is great success. Patient really enjoyed it, and I can see difference in their A1C, and that's the whole idea of having. Yes, I have two of my patients. Like I said, after the program, we did the A1C, and they went down 1 point. Wow. Yes. Yeah. So that's a great success, and I'm recommending it for all my diabetic patients. And they all were very, very impressed with the program. Yeah, it's really a valuable thing. It is not just that they are spending time, but they learn a lot, and they were very appreciative of this program. Yeah. So I hope that this will continue, and we are very happy that healthcare partner is really doing a great job in patient education, because that's very important. And most of the time, we don't have enough time to teach patients everything. Yeah. So that's really a very good program. I'm very happy.
Okay, so what did you hear there? I thought I got so much value out of that video because, number one, he got praised by his patients for doing this for them. That's awesome. That's what I want. I want him to get all the credit. We don't want any of it, because that means that we're going to get a chance to take care of more of his patients, right? You know, it solidified our value with his practice. And, you know, this video gives us credibility amongst his fellow PCPs as well, right? And at the end, I don't know if you heard that, but he promoted us to the regional payer, which is Healthcare Partners. And you know, I sent this video to them because ultimately the value is not about us. The value is what I can do for them, right? What I can do for the doctor, what I can do for the payer, what I can do for the patient, right? That is the key. So always, always, always try to create a better relationship with your referrers and your PCPs. Here's another one. I can't get meaningful connections with my patient using telehealth. How do you feel about that? Yes? No? Is it hard? Is it not hard for you? I feel the opposite. Oh, good. Awesome. I disagree. Marion says that it's possibly more difficult to connect, but it's still possible. Absolutely, Molly. For sure. Yeah. Now, I will have to tell you that, telehealth is not easy, right? It's not easy because we're so used to being in front of somebody and actually seeing those nonverbal cues, right? Those make a huge difference. Now, over time, I think you could definitely develop the skill online, but those are hard skills to learn, especially if you're so used to being there with the person. And there's other things like background noise. For those of you that do telehealth, that they don't mute themselves, and so you're hearing the dog and the road and sirens going across. I mean, you hear everything, and it kind of distracts the whole session. They're late for programs, right? And there's tons of no-shows. Well, the reason why that's happening is because telehealth is actually, like I said, one of the best ways to increase access, right? It made it infinitely easy to join at a press of a button. But if you think about that easiness also leads to people not wanting to do it or doing it because it's so easy to leave or easy to not participate, right? So the friction part of it really goes both ways, right? It can be definitely something that helps us because we can get more people, but at the same time, a lot of people just say, you know what, it's easy enough for not me to press that button and connect with you today. So some of the lessons we learned on this is be an active, create an active contributor versus a passive consumer, right? And this has to be deliberate. I mean, your program has to create that engagement to keep the interest of your patients. I'm hoping that I'm doing this for you during this presentation as well. Using the chat quite a bit, right? Having a different way to present my screen. I mean, these are all different ways that we can interact with our members to create more engagement. And somebody said, you have to be creative. Absolutely. We have to be creative. We have to give virtual hugs as well, right? One way, somebody asked me a while back, how do you give a virtual hug? Well, one way is to make sure that you let them know that it's not their fault that they have diabetes. And you have to take all the blame and shame out of your program. And I think a lot of you do, but there are programs out there that don't do that. You would be amazed that just that one thing could make a huge difference in a person's experience of your program. The other things are, of course, the camera, lighting, sound, and gestures. Yeah, those are important, absolutely. But I think more important than that really is you have to make it fun. It's funny, but when we were having in-person programs, even through telehealth, the thing that I knew that gauged the best experience for the member was that I heard laughing in the program. And I knew that the program was a success when I did hear that. Laughing is just remarkable. And you might say, well, how do you get laughing in a diabetes program? But for those of you that do it well, you do. Because everybody's in the same boat, and there's a lot of things that people don't want to talk about that come out. And some of them are things that you can laugh at because you're all together as a group of people that are living with diabetes. And then, of course, be obsessed about the member's experience. Everything we talked about enhances the positive experience. You got to make sure that that person is having the best experience that you can possibly give them, right? So how do you know if you've done all these things? I would say two things. One, the light bulb. So that's something that you're going to see in their faces, whether it's on video or in person. It's that aha moment. And for those that are in the trenches that do this, you know what I mean. When you see that aha moment, it makes you feel so great, right? Because you know they're starting to get engaged and that they get it. The second is their data. Both engagement and clinical data are important to know if you're on the right track. If you don't know your data, you have to know your data, especially if you're going into telehealth. So let me show you some data examples for our program, kind of give you an idea. Here's engagement by attendance. So our program is a 3-session program. And there's a reason why we did that, by the way, but it's 3 sessions. If they come to the first one, 89% of the time, they'll come to the second one. And then it drops, unfortunately, to 76%, but we feel that that is a pretty good indicator that our engagement is there for our members. Now, we did see 6,000 sessions last year, by the way. So attendance is really key to engagement. If you know your attendance, you know your engagement. Your clinical outcomes, right? That is key because ultimately your payers are interested in this. And you're interested in it as well because the more you can decrease an A1C, the more difference you're going to make in that person's life. So this was our A1C for the last year in 2020, 1.9 decrease in A1C for high-risk members. So we had 8.5 out of 10 people decrease their A1C that were in that high risk. But I think more importantly, 6 out of 10 members that were above 9 were below 9 after the program, right? These are key things that you have to know in your program because this is where your value is. And to be honest, this is how you tell your compelling story of your mission and your program is through data. And then the last thing we tracked was total cholesterol. We actually decreased cholesterol by 21 points on the average. 70% of our patients and members decreased their A1C below 200 after completing the program. Now, as a side note, I want you to look on the lower part of this presentation. You notice that CMS measure citation? So that wasn't there by accident. Our job is to know what our partners value and provide them through our provide those things through our services. So that is the CMS star measure, C20, D12, D14 for cholesterol. And if I'll go back and you can check out the other ones. So that's for diabetes, right? So our payers are keenly interested in those measures. And so what we do, our value to them is to show them how we're affecting those metrics. That's their metrics, right? So again, I say the acronym WIIFM quite a bit in other talks. And basically what that is WIIFM is what's in it for me. But of course, I'm not talking about me. I'm talking about what's in it for the payer, the doctor, the member, right? That's the approach that has made us successful. So how about this last one? We'll just wait until the PHE is over and go back to normal. How many of you feel that way? Like, we won't, you know what, the telehealth is difficult. We just kind of dabble in it, but everything's going to be done anyways. So, you know, we'll just wait it out, probably another 6 months or so, and we'll be back in normal. Yeah, there you go. No, the toothpaste is out. That's right, Brenda. No, there's no going back, Kate says. Absolutely. Telehealth may not be for everyone, but the genie is out. And I think the genie saying was actually said by the CMS, former CMS administrator, Seema Verna, as an analogy. And it's out and it's here to stay, right? But why should we do anything now that we're so close to reopening? Well, what if I told you that providing your telehealth diabetes service is really a matter of life and death? Would you believe me? Well, here's the data. So here's the proof. This was a retrospective study that showed that in-hospital death rates was significantly lower, 1.1 versus 11% in the well-controlled group relative to the poorly controlled cohort, right? Our goal in diabetes education and support is to help and partner with people living with diabetes to live long, healthy lives with diabetes. You know, we take pride in our success stories. And each of us that do this work, I guarantee, have many stories. Many people have been saved from heart attack, stroke, amputation, and kidney failure due to uncontrolled diabetes. So you were there for them before COVID. But can you say that you were there for them right now when they needed us the most? When the difference between surviving COVID and seeing their grandchildren for the last time is determined by their blood sugar control? It matters more than ever that we provide our services to the people we serve in any way we can, even though the difficult road of understanding and implementing telehealth is in front of us. You know, I challenge you not to wait until the public health emergency is over and go back to normal. You know, this is our chance to rise as an industry, as certified diabetes care and education specialists, to take the hard road and do what's right for the patient, and something that we promised them that we would serve them, even in our very difficult times, because it matters. It's a life and death issue. Let's not miss this opportunity like these organizations did. Let's embrace the long, hard road and understand the customer experience instead of choosing to embrace complacency, right? So let's always remember why we're doing this. We're doing it for them because they are counting on us to always be there. This is a call of action. You know, be obsessed with their experience. It's the number one thing that's going to keep them engaged and get your results. You have to look at their experiences. If they're having a bad experience, figure out how to make it better and implement that into your process. You know, think mobile first, because that's really the lowest hanging fruit until we get everybody else online and have devices. Know your data. Your data will lead you. If you don't know your data, you don't know what your program is doing. And if you don't know what your program is doing, you're not showing people the value of your program. Build relationships, continually do that. Your referring sources need to know who you are and what you do and how well you do things. Plan for the long term. You know, the genie is out. We've got to plan for the long term. We've got to make an investment in telehealth. Whether you do telehealth currently or not, it will catch up to you. And the last thing is, don't wait. You know, we have this opportunity now. There's a lot of things that make it so much easier for us to do telehealth. This is our opportunity. If you wait, you're going to squander the opportunity. So go full bore, heads down. So, and of course, that's, we're doing everything for our members. It's the reason why we got into what we're doing. That's it. So thank you so much for your time. If any of you have, well, I'm sure everybody has a smartphone, or at least if you can do a QR code, you can actually use your phone to scan the QR code, and you'll be able to download my my presentation instantly. Make it easier for you, less friction. So thank you so much for your time.
Thank you so much, Tony. As always, I always learn things. So I appreciate your being with us today. We did have a couple of questions, and people are already trying your QR code, and it's working for them. There's one I gotta find somewhere. It was in the middle of everything. I'll look for it in a second. Let me ask you this question. How are programs handling patients who are driving, obviously dangerous and not encouraged, or at the grocery store running errands during their telehealth visit?
Right. Well, I mean, it's a hazardous situation. You don't want your member ever to be in a situation like that, because number one, it's a liability for you, right? And so, so upfront on intake, it's always a great idea, if you don't do it already, is to kind of lay out the ground rules, right? This is a program for you. You need to be in a safe place. You need to be in a private place as well, right? Because if they're not driving, they may be shopping. Maybe they're pushing their cart at the Vons, Albertsons, right? And they're actually looking through the video on their mobile. So you want to make sure that you have those policies in place at the very beginning to make sure that they understand that is the ground rules. And if they ever show up on a telehealth program in that driving or doing anything else, to be honest, you have to let them know, because I want to make sure that your privacy is secure and that you're safe, we have to reschedule this session. You have to do that.
Absolutely.
Yeah.
Is it recommended or required by CMS to document patient and provider location? And do they only allow telehealth when patients are specifically in their home? What about work or private office? Does CMS care?
Right. Well, I think currently, I think it's pretty open access to everything. But I will tell you, there's a thing about telehealth that you have to be cognizant of. Because, I mean, if you think about it, if a member came to your practice and something happened to them, right, you would have the ability to get emergency care for them, right? In a telehealth system, you really don't have that option, other than you can call 911, but you have to know where they are. So one of the policies that we've implemented, and if you haven't done this, you should too, is that at the very beginning of the session, you should ask them, are you at your home location or somewhere else? And document that. Because if something happens during that telehealth session, let's say they have a heart attack or a stroke or something else is happening that you can see on video, you want to make sure that you have all the information to proceed forward. But if you don't ask that question, you won't know. Now, one of the challenges is, though, and we've had this, is homeless. Now, we've taken care of homeless people, and they are not at any location, right? But we do ask them, number one, are you in a private area? And number two, can you tell me exactly where you are, corner of what and what, right? And in those cases, we'll document that, because that's the only way we'll be able to provide the service to them at this point. But no matter what, it's always a good practice to make sure that you have that information available.
Yeah, absolutely. This one came up during the chat. When you were talking about payers and tablets, iPads in particular, the question was, did the payer actually pay for that iPad?
Yes.
Was
Absolutely.
it a private payer or a commercial payer? Or I'm sorry, a Medicare, Medicaid, or
commercial?
Commercial.
Yeah, a Medicare Advantage plan.
Okay, that's
Yeah.
good to hear.
Yeah.
I know I've heard a lot of people ask about it, a lot of talk about payers paying for devices and helping offset broadband costs, but I hadn't heard of one that actually did. So that's good to know.
Yeah, absolutely. And you never know until you have that discussion,
Right.
right? And if worse comes to worse, I would even recommend that, I mean, tablets aren't expensive. You can actually get an Android tablet for less than $100, right?
Mhm.
Your program, if it means that much to your program to reach out to people that don't have these things, buy a couple, $200,
Mhm.
right? And even if you wanted to get the broadband on it, like cellular connection,
Mhm.
try it out, do it, get some data,
Mhm.
show the value. And once you get that, go to your payers and tell them, hey, you know what, we tried it
Mhm.
on 10 members and this is what we got,
Yeah.
right?
Right. And then you did, the other part of that was the broadband. And so I'm going to put into the chat a link to about the emergency broadband benefit program. And I want to share my screen. Let's see, I got to move my thumbnails out of the way. I'll share my screen real quick. And if you're not familiar with the Lifeline program, what screen do you guys see? Do you see my email? Do you see?
See the FCC.
Okay, good. So the emergency broadband benefit program is like Lifeline on steroids. Lifeline is a program that has been around since the late 1990s. It's under the Federal Communications Commission, and it's run or administered by a company called USAC, the Universal Service Administrative Company. So the normal Lifeline program pays a subsidy of $9.25 towards either internet broadband in the home, a landline phone, or a cell phone. There are some qualifications as far as usually it's 135% or less than the National Poverty Guidelines, or that the eligible beneficiary is enrolled in Social Security benefits or a WIC program or food stamps, something like that. This EBB program actually, instead of the $9.25, it actually provides a discount up to $50 a month on one of those three things. And that's up to $75 per month if the beneficiary is on tribal lands. The other thing that this program does provide is a device. So the device has to have a retail value of $100, but the participant might only pay $10, and then the program or the telecommunications vendor would pay or get paid the difference between whatever the beneficiary paid and that retail price of $100. So I put the link in the chat. This program did open on May 12th. So that is available for those that have issues with broadband or obtaining devices. So I think we have time for one more question. Does DSMES COVID telehealth ruling require the patient to be, oh, I'm sorry, never mind. We answered that. During COVID, they can be anywhere. Okay. And there was one more in the chat. Let me see. Let me stop sharing. How do you recommend the PowerPoint's presentation when teaching?
So yeah, PowerPoint is definitely the best, one of the best ways to do it. If you wanted to become a little bit more interactive, you can do something like what I did today, which is from Prezi presentation, right? And then also another good resource is Canva. If you've never used Canva before, you can actually create slides in Canva that have motion, and that increases interaction with the person that's looking at it, because it's not stagnant.
Mm-hmm. Yeah, great. Well, I want to thank you again, Tony, for being with us today and sharing your wisdom and knowledge. Aria, I think we've got one closing slide, and there's the link to the survey. Are you going to put that in the chat as well so people can hyperlink to that? And we do appreciate your feedback on our webinar program, and love to hear if there's any other topics that you would like to hear about in the future. And for our next webinar, again, our series normally occurs every third Thursday of the month. And the next Telehealth Resource Center hosting will be the Great Plains Telehealth Resource and Assistance Center. We do not yet have a topic for next month, but the date is June 17th. And it will be just like this one, 11 to 12 Pacific Standard Time. All right, well, thank you everyone for joining us. Thank you, Aria, for hosting, and thank you for the transcription services. Have a great day, Tony.
Bye-bye.